Hypothyroidism is when the gland does not make enough thyroid hormone. The most common cause of hypothyroidism is inflammation of the thyroid gland, which damages the gland cells. Autoimmune or Hashimoto's thyroiditis is which the immune system attacks the thyroid gland. Some women develop hypothyroidism after pregnancy, often referred to as postpartum thyroiditis. Hypothyroidism is a hypothyroid state resulting from a hyposecretion of the thyroid hormones T4 and T3. Hypothyroidism is characterized by a decreased rate of body metabolism. As part of the assessment, the patient would typically be lethargic and very fatigued. The weakness, muscle aches, paresthesias, intolerance to cold, weight gain, dry hair, dry skin, loss of body hair, bradycardic, constipation, a general puffiness and edema around the eyes and face, forgetfulness and loss of memory, menstrual disturbances, cardiac enlargement, and tendency to develop congestive heart failure. A low T4 level reflects underproduction of the thyroid hormones, and it's important that you would monitor their response to the therapy. A low T3 reflects underproduction as well of thyroid hormones. An ECG could reveal a low voltage T wave abnormality. Other tests would be a 24-hour radioactive iodine uptake, thyroid autoantibodies, and antithyroglobulin. Medical management. The primary objective is to restore a normal metabolic state by replacing the thyroid hormone. Additional treatment in severe hypothyroidism consists of maintaining vital functions, monitoring ABG values, administering fluids cautiously because of the danger of water intoxication. Most patients are diagnosed and treated on an outpatient basis. And the goal of treatment is to return the patient to a euthyroid or normal state and to prevent complications. The treatment of choice is to provide thyroid hormone supplements to correct hormonal deficiency. Treatment of an elderly patient is approached more cautiously because of a higher risk for cardiac complications and toxic effects. Medication should not be given if the pulse rate is greater than 100. The treatment is considered to be lifelong, requiring ongoing medical assessment of thyroid function. Several classifications of drugs are affected by the addition of thyroid supplements, including beta blockers, oral anticoagulants, bronchodilators, digitalis preparations, tricycline antidepressants, and cholesterol-lowering agents. Because significant cardiovascular disease often accompanies hypothyroidism, the patient is at risk for cardiac complications if the metabolic rate is increased too quickly. The patient needs to be monitored for cardiovascular compromise like palpitations, chest pain, shortness of breath, or rapid heart rate during early thyroid therapy. The diet for a hypothyroid patient is generally low in calories, high in fiber, and high in protein. As the metabolic rate rises, the calorie content can be increased. A patient's intolerance to cold may extend to cold foods, making meal planning a little more difficult. Treatment consists of replacing the deficient hormone with the synthetic thyroid hormone, and low doses are initially used, and the dose is increased every 1 to 2 months based on the clinical response and serial laboratory measurements that show normalization of the thyroid-stimulating hormone levels in primary hypothyroidism. The patient begins to experience clinical benefits in 3 to 5 days, which level off after approximately 4 to 6 weeks. After the dose is stabilized, patients can be monitored with lab measurements of thyroid-stimulating hormone annually. Levothyroxine, which is a synthetic thyroid hormone replacement, is used to return the patient to a euthyroid state. Dosage is 1.5 to 2.5 milligrams per kilogram PO daily. If the patient becomes hypertensive and there is an increase in the thyroxine level, it may indicate that the levothyroxine dose needs to be decreased. When discharging to home, explain all the medications, including dosage, potential side effects, and drug interactions. Instruct the patient to check their pulse at least twice a week and to stop the thyroid supplement and notify the physician if the pulse is greater than 100. Teach the patient about the thyroid gland and hyperthyroidism as well, and about any complications such as heart disease and edema. Myxedema coma is a life-threatening condition in which patients with underlying thyroid dysfunction exhibit exaggerated symptoms of hypothyroidism. Precipitating factors include infection, trauma, surgery, stroke, heart failure, central nervous system depressants. Hypothyroidism depresses the metabolic rate, which seriously affects the rest of the body's symptoms. So make sure you question any meds that are sedating. Signs and symptoms of myxedema coma are below normal temperature, decreased breathing, low blood pressure, low blood sugar, and being unresponsive. The patient would have hypothermia, hypoventilation, decreased mental function, cardiac or respiratory failure. Looking at the body systems, the skin is coarse and dry, possibly a carotene color. periorbital and facial edema, neurologically, obtunded, coma or seizures, delayed reflexes. Gastrointestinal, decreased bowel sounds. Endocrine, the thyroid may be palpable, enlarged, or nodular. The nursing diagnosis potentially could be decreased cardiac output related to bradycardia and decreased stroke volume. So an outcome criteria would be patient is alert and oriented, blood pressure systolic is 90 to 120 millimeters of mercury, the mean arterial pressure 70 to 105 millimeters of mercury, heart rate 60 to 100, urine output 30 mLs an hour, and peripheral pulses are palpable. So the patient needs to be monitored on the ECG for dysrhythmias or profound bradycardia that can adversely affect the cardiac output. Monitor central venous pressure if they have a central line, or a pulmonary artery pressure if they have a swan, and also make sure to measure the blood pressure. Monitor fluid volume status and check in the urine output hourly and determine the fluid balance every 8 hours. Assess the cardiovascular status and note the quality of the peripheral pulses and capillary refill, and observe for increased jugular vein distension and pulsus paradoxus, which may indicate pericardial infusion. Administer the IV fluids to carefully monitor for fluid overload and development of heart failure. Vasopressor agents may be used if hypotension is not the result of volume administration and if the thyroid replacement has not had time to act. Carefully monitor the patient for lethal dysrhythmias. Written instructions will be helpful to a patient because initially a hypothyroid patient may be unable to remember to take medications and other aspects of self-care. Because the treatment regimen is somewhat complex, teaching should be initiated way before discharge, and family members or friends should be included in the teaching because the hypothyroid patient may forget some aspects of the treatment plan. Pretibial myxedema and its inadequate thyroid hormone synthesis. Cretinism is when hypothyroidism is present from birth and accompanied by developmental abnormalities. This picture shows deposits of hydrophilic mucopolysaccharides in the dermis, and this can cause facial feature thickening and doughy skin induration.